Hello, welcome to Pancreas Pathology. This 6-part series will start with diffuse pancreas disease, specifically looking at acute and chronic pancreatitis. Let's go ahead and get started then with acute pancreatitis. And we're going to define acute pancreatitis as inflammation of the pancreas acini cells causing pancreatic enzymes to be leaked into the tissue, which results in damage and causes the pancreas to malfunction. So let's go ahead and unpack that definition a little bit more. We know that pancreas and itis, right away, that should tell us inflammation of the pancreas. But what we need to specifically look at is where that inflammation is occurring. We need to know that the acini cells are responsible for creating the pancreatic digestive enzymes. And when the ducts that carry those enzymes, when those ducts get blocked up by a tumor, by a gallstone, by inflammation or other swelling of the pancreas, we're going to see those enzymes kind of back up into the pancreas, and eventually they're going to have to go somewhere. They're going to start leaking out. We also know when those enzymes exit the duct, their main job is to start to digest. So as those pancreatic enzymes start to get backed up into the pancreas, eventually they're going to leak out, and once they do, they're going to start digesting the body, basically. And so because of that digestion, the pancreas itself is going to start to malfunction, and we're going to see lots of complications arise because of it. Now, the number one cause of pancreatitis is biliary disease. That is typically because a stone is created in the gallbladder, somehow gets into the common bile duct, and then causes the common bile duct to back up, which might cause the duct of Wirsing to back up, and then we've got a lot of plugged up ducts. The second cause of acute pancreatitis then is alcoholism. So number one is biliary disease, number two is alcoholism. Now there are a bunch of other causes for acute pancreatitis. What you need to pay attention to mostly with these is that these diseases somehow disrupt the homeostasis of the body and the pancreas. Being pregnant really messes with a lot of things. Drugs cause other organs to not work very well. Inflamed peptic ulcer, that's going to cause more issues within the duodenum. So anything that can kind of disrupt how the enzymes are released into the duodenum normally can cause acute pancreatitis. Now, patients that present with acute pancreatitis are going to have some very obvious clinical symptoms. The main one is going to be epigastric pain. Remember, the epigastric region is the region by the stomach, so we consider that right below the xiphoid process, right in the middle of the abdomen. So lots of pain there, right where the pancreas resides. That pain quite often then wraps around to the back and quite often causes nausea and vomiting. Now we know biliary disease is the number one cause, and when we see biliary-related pancreatitis, what tends to happen is that, again, a stone gets lodged somewhere, and when that stone gets stuck, it's going to cause severe, localized, and acute pain. So that's going to be severe pain, comes out of nowhere, hits the person, and they're just on the ground in pain because the stone all of a sudden blocked everything up. Alcohol-related pancreatitis, though, on the other hand, is going to be a little bit slower. So it's going to be kind of this general achiness throughout the area, and it's going to kind of be a slow onset of pain. Now, when these patients finally do make it in to the doctor because they are in pain, one of the first things that they're going to do is run a basic metabolic panel. And in that basic metabolic panel are going to be some pancreas enzyme tests. So we have amylase and lipase. Now, if a patient comes in right at the beginning of their acute pancreatitis, what we will see is an increase in serum amylase. It rises very quickly, and then it's going to fall in the next 3 to 5 days. So if they come in day one of pancreatitis, that amylase is going to be super duper high. However, if they come in day 4, day 5, after they've been having this pain, their amylase might be back almost down to normal. So that's where serum lipase comes in as a better indicator of pancreatitis. Serum lipase is going to slowly rise during the initial phase of pancreatitis, but the nice part about it, for diagnosis purposes at least, it's going to stay elevated for 8 to 14 days. So now we've got a patient who kind of had this awful pain that that onset of pain comes on. Maybe they don't go to the doctor right away. They finally decide day 4, day 5, like, oh, I really got to go in. This hurts too much. Their serum amylase at this point is already back to normal, but their lipase should still be elevated. So that is why we consider serum lipase a better indicator of pancreatitis. Now, if a patient is diagnosed with acute pancreatitis, then we want to make sure that we're getting fluids and then pain meds to control the pain that they're in. We want to talk about some nutrition support. So sometimes that means making the patient NPO, where they're not using their pancreas, because if the pancreas gets activated, we digest our food or we ingest our food, the pancreas gets told by all the hormones in the body and everything to start making enzymes. Well, then if they're already not functioning well, or if there's already a leak, then they're going to just leak more enzymes out into the body. So quite often we have these patients be NPO, so they're not using their pancreas in the same way that people who are eating would use it. Depending too on what else we see, we might decide to do surgery for treatment as well. As far as prognosis goes, if it's detected very early, most people are just fine. They'll get the care that they need, get the medications and the treatment that they need, and they're going to be just fine. However, though, acute pancreatitis can go bad really quickly. There are a lot of complications that can go along with it. If a lot of damage occurs or if necrosis of the organ starts to occur, then we're a little bit more concerned about their outcome. Here are some pictures then of acute pancreatitis. One of the things that we will see with pancreatitis is a heterogeneous pancreas. In this picture too, we can also see that the pancreas looks kind of fluffy. The medical term for that then is edematous. We'll also notice that it's much more hypoechoic. Usually the pancreas is the brightest organ compared to liver, spleen, and kidney. We will notice in acute pancreatitis that the pancreas looks darker than the liver. And then we might also see some very prominent vessels within the pancreas as well. Remember, anytime there's an inflammation in the body is usually going to try to send some extra blood to the area to get more of those, like white blood cells, macrophages, all those guys down there to try to help fix the situation. So sometimes we see some extra blood flow to the area. So again, we have our pancreas tail, body, neck, part of the head, and the uncinate process here. This is the splenic confluence with the splenic vein running posterior to it. We have the aorta here and the spine. So all of this is very kind of large, fluffy, edematous, and much darker than what we would expect the pancreas to be. The second picture here again shows us some swelling of the pancreas. We can see how rather large it looks. It's taking up a lot of space in that mid-abdomen region. We can also see increased lobulation, so we can kind of see this rough border along the edges. Again, it's very large, and what we might see is that this head becomes so enlarged that we're going to start to see the IVC become compressed. So this is the IVC down in the corner here. We might see this head swell so much that it starts to push down on the IVC. Another picture here is showing a dilated duct of Wirsung. Remember, the duct of Wirsung is the main duct that runs through the pancreas. If we can see it on ultrasound, it doesn't mean that it's necessarily dilated, but it's not typically something we see in a normal pancreas. So if you see the duct of Wirsung, you might just want to put some calipers on it just to measure it and make sure that it's still within normal limits. Some other things that we might see with acute pancreatitis, because it is so closely related to biliary disease, we might see some dilated bile ducts in the area, we might see stones at the head, and we might start to see some fluid collections around the pancreas as well. Now, there are some key terms that go along with acute pancreatitis that are worth knowing. We can actually define acute pancreatitis even further into mild, moderate, or severe acute pancreatitis. Now, most patients are going to come in with mild acute pancreatitis. This basically just means that it is localized to the pancreas, and that is the core center of all the problems that they're having. At the moderate level of acute pancreatitis, we're starting to see the liver is going to be affected. We're going to see that the pancreas actually isn't working very well anymore. We're going to see some more systemic issues start to arise. Once we get to a severe acute pancreatitis, we're going to see that the pancreas is basically completely shut down. It's not working anymore. And then that's going to start to affect how the liver operates, how the kidneys operate, and we're going to see multiple organs start to fail. So most people do come to the doctor with that mild acute pancreatitis. However, if it's left untreated, or if the patient maybe doesn't seek treatment as quickly as they should have, we will see that progress into a moderate or severe acute pancreatitis. And another key term that we need to think about is the idea of the CT. We know that ultrasound isn't super accurate at seeing the pancreas, so we want to remember that there are other imaging modalities that are helpful in diagnosing pathologies within the abdomen. And one of those happens to be the CT. Now, the CT is also limited as to some of the things that they can see, but one of the ways that they can enhance the way that they see the abdominal organs is to administer some sort of contrast. Now, contrast comes in two forms. It comes in intravenous, which is injected in through a vein through an IV. That's going to be more to light up blood vessels throughout the body. Or they'll take an oral contrast. The oral contrast is usually ingested through the mouth. It then coats the stomach and the bowel to reduce the amount of air to help visualize the abdominal organs. So CT is kind of the gold standard then to evaluate the pancreas, since it is much better seen and a global view is obtained. Another concept closely related to acute pancreatitis is the idea of the ERCP. ERCP stands for endoscopic retrograde cholangiopancreatography. And I know that we covered this briefly in the biliary pathology lectures, but it goes to say that it also is helpful in evaluating the pancreatic ducts as well. As a quick overview, a camera is inserted into the esophagus, threaded through the stomach and into the first part of the duodenum. The camera then allows visualization of the stomach, of the duodenum, and the ampulla of Vater. A small probe then, or catheter, is threaded through the ampulla of Vater, and from there the physician has the choice then to travel into the bile ducts or to look through the pancreatic ducts. This is a helpful tool to visualize for any filling defects that might be associated with a stone or other blockage at the ampulla of Vater or the proximal portions of the ducts. Switching over to chronic pancreatitis then, we're going to define chronic pancreatitis as permanent damage to the pancreas due to recurrent acute pancreatitis resulting in impaired exocrine and endocrine function. So as most of our chronic diseases present, it usually has to do with having a long-term acute disease. So we talked about chronic cholecystitis happens after many bouts of acute cholecystitis. Chronic pancreatitis is the same idea. Lots of bouts of acute pancreatitis. The more often you damage something, the more likely the organ will permanently remain damaged. And in the case of the pancreas, it will become so damaged that both its exocrine and endocrine functions are impaired. Now with this one, the number one cause is alcoholism. And let's think about that. We know that acute pancreatitis' number one cause is biliary. Well, we can fix biliary. We take the gallbladder out. That usually gets rid of the stones. Bada bing, we're good to go for most people. Alcoholism, if it is not fixed, will continue to insult the pancreas, will continue to cause acute pancreatitis. The more acute pancreatitis bouts that you have, the more likely you're going to develop chronic pancreatitis. So it makes sense then that alcoholism is the number one cause. Of course, biliary disease can continue on if the patient, for whatever reason, has declined intervention for their biliary disease, then it can continue to cause acute pancreatitis, which leads to our chronic. And then we also know that there is some relationship with smoking, high blood calcium, and high cholesterol. Clinically, these patients are going to present a little bit differently than the acute pancreatic patients. With the chronic pancreatitis, they're going to have transient pain. So that means that it's going to be pain that comes and goes, really no rhyme or reason as to why it is coming and going. And they're also going to start to notice some pancreatic dysfunction. Remember that chronic pancreatitis will impair how the pancreas functions. And so what we're going to see is glucose intolerance. So the patient can no longer really ingest carbohydrates and still process them the same way. They might be unable to digest food in general. And so with that, what we tend to see is fattier poop, or kind of like undigested particles of food, or they might be unable to absorb nutrients. So we might see that they start to actually have decreased vitamins, decreased calcium in their blood because they're no longer able to break down the food to the point where then they can use it as a digestible building block for the rest of their body. Lab tests happen to typically be normal. So serum amylase and serum lipase are typically normal, maybe slightly elevated if they have chronic pancreatitis. And as far as treatment and prognosis goes, they typically are going to need some sort of pain management. There are some other treatments that can help them kind of detox a little bit and to control how their body is able to function with a limited pancreas. Otherwise, surgery can also be helpful. Typically, the prognosis on these it's going to be moderate. They are going to have lifelong complications due to a decreased function in their pancreas. And it definitely is a poorer prognosis if the patient is younger when diagnosed with it. So if we're looking at maybe a very young adult who is chronic alcoholism for years on end, very heavy drinker, they're more likely going to be diagnosed with chronic pancreatitis very early, and that just doesn't bode well for a long game. As far as ultrasound goes, the chronic pancreatitis pancreas is going to be very heterogeneous. It's going to appear kind of small, so we call that atrophic or shrunken. We expect that the pancreas takes up a good portion of that midline. We're going to see that it's very difficult to see, and it's not because it's hiding behind gas or behind bowel, it's just because it has become much smaller. Another thing we'll see too then is some fibrosis through the pancreas. If you think back to how the liver looks as it gets damaged and kind of heals itself, the same idea is going to happen with the pancreas. It's going to start to get kind of this funky look to it. It's going to have these bright fibrotic strands going through it. Another thing that we see with chronic pancreatitis is that it's going to become rather echogenic. So we know that the pancreas is already the brightest organ in the abdominal cavity. However, this is going to get extremely bright in the setting of chronic pancreatitis. And this might also be secondary to the fact that the pancreas has developed calcifications. Some other things that we'll see with chronic pancreatitis, again, then, is going to be the dilated ductal Wirsung, dilated bile ducts, and stones. If those components are still there, we might see some fluid collections around, and more importantly, we might start to see a portosplenic thrombosis. So if you recall, the splenic vein travels on the posterior side of the pancreatic tail, and then the confluence is right at the pancreatic neck. What we're going to see then is possible thrombosis within the splenic vein as it confluences with the superior mesenteric vein to create the main portal vein. So some thrombosis in this area is possible in the setting of chronic pancreatitis. A subset of chronic pancreatitis then is calcifying pancreatitis. On CT, these show up as bright echogenicities throughout the pancreas. We can see these on ultrasound as well. Again, there will be bright echogenicities with some shadowing behind them. So calcified portions within a pancreas is a definite indication for chronic pancreatitis. All right, let's move into part 2 then, pancreatitis complications. So pancreatitis, acute and chronic pancreatitis, can then result in complications that are somewhat diagnosable by ultrasound. So we're going to take a look today at fluid collections, pseudocysts, necrotic collections, pancreatic ascites, hemorrhagic pancreatitis, phlegmonous pancreatitis, and finally pancreatic abscess. Starting with fluid collections, as a pancreatitis complication, what we will see is fluid outside of an edematous pancreas, and we commonly see this with severe acute pancreatitis. So remember, with acute pancreatitis, the pancreas looks kind of darker, it looks kind of fluffy, that's the edematous part of it. With fluid collections, we're going to start seeing those enzymes leaking out and kind of these anechoic areas starting to surround the pancreas as that fluid starts to collect around the pancreas. This is typically going to be seen in the lesser sac, so that's the area between the stomach and the pancreas. The second most common space on after that is the anterior pararenal space, which is near the tail and spleen. We may also see some fluid collections near the mesocolon, the pararenal space, or the peripancreatic space. Now, as far as timeline goes, we are typically going to see fluid collections start to appear within the first 4 weeks of the initial onset of the pancreatitis. And treatment for fluid collections, they can resolve on their own, but they might need some sort of intervention like drains or surgery. As a reminder where the lesser sac sits, remember that the peritoneum is made of the greater sac and the lesser sac. The lesser sac is the area through the epiploic foramen, which is housed by the portal triad. So you kind of scoop underneath the portal triad, and that is our only entrance into the lesser sac of the peritoneum. The pancreas then sits in this area, so we see that the lesser sac typically sits in between the pancreas tail and the stomach. As far as ultrasound goes, then, we are going to see multiple variants of fluid collections depending on how long they've been there and what else they're kind of doing to the body in that area. Typically, though, we're going to see anechoic fluid surrounding parts or all of the pancreas. There might also be some echogenic loculations or some solid components within the fluid collections. Those are going to be a little bit more difficult to identify, though, as bowel is also in the area, which can kind of obscure some more of those solid parts. When you start to have fluid collections, they're usually going to be small slivers of fluid that kind of pop up along the periphery of the pancreas. This fluid collection is actually rather large, sitting in that lesser sac. Remember, the stomach is kind of up in this area here. And we're starting to see some of those solid components within this fluid collection. Now, as those fluid collections sit within the body, they are going to kind of start to collect and mature upon themselves, and that is where we get a pseudocyst. So the pseudocyst then is mature fluid collections that become walled off due to pancreatitis, necrosis, trauma, or hemorrhage. And these are typically going to be filled with amylase. So again, we have acute pancreatitis. Within the first 4 weeks, we're going to start to see these fluid collections start to form around the pancreas. That is the pancreatic enzymes starting to leak out into the body. After those fluid collections have a chance to sit in the body and mature, not only are they probably causing quite a bit of damage to the soft tissue around them, they're going to kind of start to get walled off. The body doesn't want this fluid hanging out there, so the body's going to do its best to kind of wall this off and try to keep it from damaging the body further. So with pseudocysts, we see what looks like a cyst with a thicker wall because the body has figured out how to wall this off. Now, pseudocysts are mature fluid collections, so they also typically show up where those fluid collections like to show up. So that's most likely in the lesser sac or in the pararenal space near the spleen. We can see pseudocysts outside of the lesser sac if the fluid was able to leak through the epiploic foramen or the foramen of Winslow and make its way into the greater sac. The timeline on these then is going to be within 4 to 6 weeks of pancreatitis. So the fluid collections themselves are within the first 4 weeks. Pseudocysts are the next step and show up between 4 to 6 weeks. Treatment for pseudocysts, they must be drained. Otherwise, if they rupture, we're very concerned because that patient has a 50-50 chance of dying after it ruptures. The biggest problem with the pseudocyst is that it is digestive fluid within the body. And if we start to see that fluid hanging around areas such as like blood vessels, then the fluid can kind of eat through the wall of the blood vessel, and it can start to cause lots of issues with bleeding within the abdomen. So here we have a rather large pseudocyst. It has anechoic contents. It has thick echogenic walls. It has some internal debris to it as well. And because of where they like to sit, we need to be very careful that we don't mistake this for a fluid-filled stomach. So if you think about it, you have the pancreas. If you have a patient with epigastric pain, you think they might have pancreatitis. And then you're looking around a little bit more and you start to see this fluid-filled structure. Well, you need to know, is that the stomach full of water or is that a pseudocyst? So we want to make sure that we're rolling the patient around, watching for any peristalsing of the stomach wall, looking for the rugae of the stomach. That's going to be kind of like these little rough bumps along the outside of the stomach. And we're going to look for that fluid then to move on as it gets digested into the duodenum. So if you have a consistent and persistent walled off collection, it most likely is going to be a pseudocyst in the setting of pancreatitis. Necrotic collections then is an intrapancreatic or an extrapancreatic fluid that has caused surrounding tissue to die. So remember, we can have those fluid collections. Those are going to happen within the first 4 weeks. The body's going to try to wall those off, creating the pseudocysts. Those pseudocysts and just that fluid hanging out in the body is going to start to digest the soft tissue within the abdomen. And as it does that, it's going to eat through blood vessels. And then we're going to have areas of soft tissue that don't have any more blood going to them. And because of that, they're going to start to die. So we call it necrotic collections or necrotizing pancreatitis, and where areas surrounding the pancreas or even parts of the pancreas start to die because they have either A, been kind of digested, or B, no longer have blood flow to them. Because, again, the fluid that leaks out of the pancreas likes to collect in the lesser sac, we're most commonly going to see necrotic collections appear in that area, but it can also appear again anywhere where we see those fluid collections. The CT here then shows us an example of necrotic collections. The stars on the are sitting on the pancreas, and then the arrowheads are actually showing areas of necrosis. On ultrasound then, what we are going to see is a heterogeneous area. Typically in those areas that fluid likes to collect, we're going to see liquid and solid components. We're going to see loculations within. They're typically very well-defined areas, and then they're going to be surrounded by areas of necrosis. So again, we just kind of have a funky-looking mass near the pancreas. We have the solid and liquid components. It is difficult to tell necrotic tissue by ultrasound, but it does just kind of take on a kind of yuck appearance compared to healthy tissue. Another complication of pancreatitis is the pancreatic ascites. So pancreatic ascites occurs typically when a pseudocyst ruptures and allows that fluid to flow into the peritoneum. Now, there are some other causes of pancreatic ascites. Basically just happens when the pancreas is so malfunctioning, it kind of causes the liver to malfunction as well, and then that will start to build up ascites. But we consider mostly pancreatic ascites to be free fluid within the abdomen that has a strong presence of amylase and protein. So if a patient has fluid within the abdomen, they go and do a paracentesis on it, send it down to lab, we would expect amylase and protein to be in it if it is a pancreatic source. So ultrasound is going to show non-specific complex fluid in the abdomen. So that complex fluid, part of it means that there's going to be kind of like these free floating speckles within the fluid instead of it just being like a pure anechoic fluid. And then again, it is going to follow the presence of a pseudocyst. Maybe there one day, next day, there's no evidence of that pseudocyst, suggesting that there may have been a rupture. Hemorrhagic pancreatitis occurs as a progression of acute pancreatitis in which vessels rupture because of the leaking of those enzymes from the pancreas. So if a patient has acute pancreatitis, they're typically going to start to develop those fluid collections. Remember those fluid collections do contain digestive enzymes. As those fluid collections sit in the body, they're going to sit around blood vessels, eating away at the walls of the blood vessels. And as those digestive enzymes sit around the blood vessels, they might start to eat through the wall of the vessel. And if they are successful in eating all the way through the wall, then the vessel will start to hemorrhage or bleed into the abdomen. As far as ultrasound goes, then hemorrhagic pancreatitis is actually going to take on a few different looks. And that has to do everything with the age of the blood. So if there were fluid collections or a necrotic collection or some collection of enzymes. They start to eat through a blood vessel and the blood vessel starts bleeding. New blood is going to be well-defined, homogeneous, typically kind of anechoic. A little bit older blood is going to have some more solid components in it. And then super old blood is going to actually turn back to mostly cystic. So new collections are going to be mostly anechoic, older collections are going to be mixed, and then super old collections are going to again be anechoic. Another complication of pancreatitis is the idea of the phlegmonous pancreatitis. Now, whenever you have an infection, like you do with pancreatitis, the infection or the inflammatory process can start to move away from its origin. And when it does that, the body can do one of two things. It can just let it go, or it can try to wall it off. So the version where it just gets let out and it just kind of flows where it wants is the phlegmonous version. So basically what happens when a phlegmon is created, or the phlegmonous pancreatitis, the infection starts to spread along fascial planes. So we'll see it run along the abdominal wall. We'll see it run through the fat tissue. We'll see it run through the peritoneum. And what ends up happening is kind of get this odd, indistinct, something's wrong, but you can't measure it kind of looking appearance to the area that's infected. Typically, you'll hear the term fat stranding on CTs. It just means that the fat is very bright and kind of stringy looking. And so what happens is that pus and necrotic tissue is just kind of spread out in this irregular way throughout the abdomen. On ultrasound then, we'll see this really ill-defined mass, typically again in the lesser sacs. It's going to appear wherever those fluid collections like to be. Typically, it's going to be a little bit more on the hypoechoic side. The fat might be a little bit more echogenic, and it's actually going to have some through transmission. So in this example here, when we talk about that there's really no, we can see that we kind of have like an irregular border here. There's really no border that ends. There's really no clear wall to a phlegmon. And so you can kind of see those little strands. They're growing along the fascial planes. You'll see these kind of long strips of irregularity. Now this is different from the abscess, where the same thing is happening. It's pus and necrosis and kind of gross things happening, but the body's figured out how to wall that off. So the phlegmon just kind of gets to go wherever it wants, where an abscess is going to be more walled off. Speaking of abscess then, pancreatic abscess are again a progression of pancreatitis. If a patient had necrosis or a phlegmon formation, it can then move to an abscess where the body actually walls off the inflamed tissue or the infected tissue. Most abscesses are going to appear well over 4 weeks, so we've already had an opportunity for the fluid to collect. We've had an opportunity for it to become necrotic, and at that point it's either going to become a pseudocyst or it's going to become a phlegmon/abscess. People who develop abscess are more likely going to be those who developed pancreatitis due to surgery. So they have some sort of bacteria that got entered into the body that caused the pancreatitis that will progress into an abscess. On ultrasound then, we're going to typically see a hypoechoic mass that should have some definition to it, but is typically not going to have a completely walled off version. So you can see here, we're kind of starting to lose the wall that we can see up here, but it's definitely going to be more of a collection in one area compared to the phlegmon. It's also going to have very thick walls. There might be septations in there, and there might also be some air within there as well. Let's move into our third section then, the multicystic pancreatic diseases. This is going to include autosomal dominant polycystic disease, von Hippel-Lindau syndrome, and cystic fibrosis. Autosomal dominant polycystic disease is a hereditary disease, and it causes multiple cysts to appear in the organs. Typically, the liver and the kidney are the most commonly affected, but cysts can appear in the pancreas as well. This disease also is more of a mid-life disease, presenting with symptoms between the ages of 30 and 40. However, younger children have been recognized to have this disease as well. Being an autosomal dominant disease, the hereditary chance of inheriting this disease is 50%, meaning that only one parent needs to have the disease to pass it along to 50% of their children. On ultrasound then, it'll appear as very well-defined cysts, and they can vary in size from very large to very small. We have a cross-sectional CT showing the liver, kidneys, and pancreas all exhibiting multiple cysts. Another multicystic disease that can appear is something called von Hippel-Lindau syndrome, or VHL. Now, VHL is another inherited disorder, and it can cause cysts to appear in multiple organs of the body. So pancreas and a VHL patient, we definitely want to take a look at the pancreas for cystic structures. Now, another thing that occurs with VHL is the growth of solid structures, and these solid structures can actually be benign or cancerous. And when a person is diagnosed with VHL, usually in their young adulthood, they are going to start to grow tumors called hemangioblastomas. And those can develop anywhere within the body, but they are basically made of kind of a ball of blood vessels. But another tumor that can grow on the pancreas that is associated with VHL is something called a neuroendocrine tumor. So not only do we really want to make sure that we're looking for cystic structures on the pancreas, we want to make sure that we're checking out for any solid growth on the pancreas as well. Now, on ultrasound, we're going to see very well-defined cysts. If they are just cystic structures, we might start to see some calcifications within those cysts. There could be one cystic structure or multiple, and they are going to vary in size. The last multicystic disease that we want to talk about then is cystic fibrosis. Cystic fibrosis, again, is another hereditary disease that affects the cells that produce mucus, sweat, and digestive juices. So quite often you think of cystic fibrosis affecting the lungs, because those are going to produce mucus, but it actually can affect the pancreas as well, because it's one of those digestive organs. Basically, what happens with cystic fibrosis is that it causes these fluids, like mucus, sweat, and digestive juices, to become thick and sticky. And when they become thick and sticky, they just don't flow the way that they're supposed to. And so they start to form these plugs in the tubes or ducts that they come out of, and then we'll see blockages start to occur. So then in the setting of cystic fibrosis and the pancreas, the digestive juices get stuck within the ducts and causes kind of a buildup of juices behind it, thus causing a multicystic appearance to the pancreas. On ultrasound then, we're going to see what we call fatty replacement of the tissue. So more fat invades into the tissue of the pancreas, so it'll be a very echogenic pancreas. We might see some calcifications within the pancreas. The cysts that we're seeing are actually those mucus plugs with some backup of juices behind it, and they might be kind of irregular, unilocular, or multilocular cysts. Moving on to our fourth section of pancreas pathology, we are going to discuss the cystic pancreatic neoplasms. Now, we just discussed in section 3 multicystic diseases that affect multiple organs within the body, causing multiple cysts to appear on those organs. In this section, we are going to focus on the pancreatic neoplasms that appear as cystic structures. Now, cystic pancreatic neoplasms are actually very, very rare. If they occur, they really only account for about 10 to 15% of all cysts that appear on the pancreas. So they are very rare, and they do all have varying potential to become malignant. If they do become malignant, they only account for 1% of all pancreatic malignancies. So not only are they rare to see, it is even rarer for them to turn into cancers. But we want to make sure that we are reviewing them as they are visible by ultrasound and a potential diagnosis for our patients. Slide here. We're going to take a look at a very brief overview of these cystic neoplasms, looking at the name of the neoplasm, any alternative names that they might have, the appearance, incidence, and malignancy rate of each neoplasm. So there are 4 basic neoplasms that you need to know: the serous cystic tumors, mucinous cystic tumors, intraductal papillary mucinous neoplasms, and solid pseudopapillary neoplasms. As you are reviewing this chart, I want to point out that the serous cystic tumors and the mucinous cystic tumors both have alternative names, so those alternative names are going to be important, and that the serous cystic tumor has the lowest potential to become malignant, where the mucinous cystic tumor has the most potential to become malignant. The fifth part of our pancreas pathology brings us to endocrine pancreatic neoplasms, covering the insulinoma and the gastronoma. Insulinomas are a functional endocrine pancreatic neoplasm. They are also known as B-cell tumors, as they arise from the cells that produce insulin. What makes them functional is the fact that they produce excess insulin. So these are the most common functional tumor, comprising about 60% of pancreatic endocrine tumors, and they typically are benign, but do end up being malignant about 10% of the time. So insulinomas arise from the B cells of the islets of Langerhans. That's why they're known as B-cell tumors. The B cells are responsible for making insulin. When there's a tumor of these B cells, the B cells start to produce excessive amounts of insulin, thus getting our functional endocrine neoplasm, the insulinoma. As far as incidence rate goes, we typically see these in the 4th to 6th decade, so 40 to 60 years old, and then actually is part of our classic triad. We have a patient who is 40 to 60. They come in with a hypoglycemic event, and they find relief with IV glucose. So if we think about it, we have this 40 to 60-year-old who is hypoglycemic because they have too much insulin circulating in their blood. That insulin is telling the cells to soak up the glucose. So now they have really low blood sugar, hypoglycemia. So they come in, they are probably quite a bit out of it, maybe lethargic, just not functioning well. We give them sugar. Everything starts to waken up and they find relief. Some other things that can come along with insulinomas, and this is basically the side effect of being hypoglycemic, is heart palpitations, headaches, confusion, sweating, kind of pale, and if it goes on long enough, they can actually fall into a coma. Lab tests for these patients then are going to have high insulin, because again, that tumor is excreting excessive insulin, telling all the cells to soak up that glucose, lowering the blood sugar, and causing lots of problems. Treatment for these patients then is going to include surgery to get rid of the insulinoma. We got to get those excessive cells out of there. And then we also want to make sure that we're following up with nutrition therapy, making sure that they are feeding themselves appropriately. If this happens to be one of those rare insulinomas that turns malignant, the prognosis is actually quite a bit poorer, and even worse so if it metastasizes. So remember again, the B cells, the beta cells, are part of the islet of Langerhans. The islet of Langerhans is home to all of our endocrine functions, where the exocrine function happens out with the acinar cells. Endocrine is all the hormonal stuff that happens. Insulin is a hormone. So beta cells, alpha cells, gamma cells, delta cells, all of that is in the islet of Langerhans. All of those can actually develop tumors, but the beta cell and the gamma cell are the two that we're going to talk about. On the pancreas then, we will see a well-encapsulated tumor somewhere in the pancreas tissue. If we put color on it, they typically are hypervascular, and they can also present with some calcifications around. So in this image here, we have the pancreatic tissue. We have a well-encapsulated tumor within the pancreas, and we actually have the pancreatic duct, the duct of Wurtzung, kind of visible here. Hard to tell if it's actually dilated beyond normal limits. Now, another functional endocrine pancreatic neoplasm is the gastronoma, and these are also known as G-cell tumors because they arise from the gamma cells, and the gamma cells are responsible for producing gastrin. So gastrinomas are the second most common functional endocrine neoplasm, and these ones are going to be malignant 60% of the time. So let's walk that back for a second. insulinomas are the most common. They represent 60% of all endocrine tumors on the pancreas, but are only malignant 10% of the time. Gastrinomas are the second most common endocrine tumor, but these are more likely to be malignant at a rate of 60%. We find that gastrinomas are most commonly associated with a disease called Zollinger-Ellison syndrome. And Zollinger-Ellison syndrome is identified when a patient has peptic ulcers and excessive gastrin. Now, that excessive gastrin might be due to a gastrinoma, where the gastrinoma is going to cause excessive gastrin to be released. That excessive gastrin then tells the stomach to release more hydrochloric acid and more pepsin. And then with that extra hydrochloric acid and pepsin out there, that is where these peptic ulcers start to pop up, thus the diagnosis of Zollinger-Ellison syndrome. Typically, we are going to see gastrinomas in younger adults and those with histories of peptic ulcer disease. Some other clinical signs and symptoms are going to be diarrhea and ulcers in unusual locations, like further into the duodenum. Now, treatment and prognosis for the gastrinoma: if it is benign, typically they're probably going to take it out just to help the patient out in that sense, but they can also put them on proton pump inhibitors, which tells the body to not make as much hydrochloric acid, so it's trying to kind of counteract what the gastrin is doing. They can do surgery to get rid of the tumor. They can do a gastrectomy where they remove the stomach, and they can also do chemotherapy. As long as they can get the tumor out successfully, prognosis is actually pretty good with these. This diagram is just to remind us again that the G cells secrete gastrin. They are part of the islets of Langerhans, where all of the endocrine cells hang out. On ultrasound then, we typically will see multiple lesions within the pancreas or even in the duodenum, and they are actually very difficult to see with ultrasound. If they are big enough or if the pancreas is visualized well enough, we might be able to aid in the diagnosis. Here in this example, we can see the pancreas here, and this tiny little darker spot here, this is the gastrinoma. Our final section of pancreas pathology brings us to exocrine pancreatic neoplasms and other cancers, including adenocarcinoma, metastases, and lymphoma. So adenocarcinoma is the most common primary neoplasm of the pancreas, and it arises from the exocrine portion of the pancreas. So remember, we had endocrine tumors, the insulinoma and the gastrinoma arising from the endocrine islets of Langerhans. Adenocarcinoma is going to arise from the exocrine portion, which is the ascites cells and the ductal components of the pancreas. Adenocarcinoma is the pancreatic cancer that most people talk about. If somebody says I have pancreas cancer, it is usually the adenocarcinoma. It is the fourth most common cause of death that's related to cancer. Patients who are more likely to develop adenocarcinoma include men who are over the age of 60, who have a history of smoking, high-fat diets, diabetes, and chronic pancreatitis. Clinically, these patients are going to present with classical cancer symptoms, including loss of appetite, weight loss, jaundice, epigastric pain, and a Courvoisier gallbladder. Lab tests are going to show an increase in amylase and lipase, and most likely also an increase of ALP if the liver is involved. In a patient who is diagnosed with adenocarcinoma, there are actually few options available to them, as the disease is typically not found until its late stages. However, a Whipple procedure may be done, or a pancreectomy. Chemotherapy can also be attempted to shrink the tumor. However, regardless of the treatment, prognosis is typically poor, with less than 8% of those diagnosed with adenocarcinoma are still alive at the 1-year mark. On ultrasound, we are typically going to see a hypoechoic mass at the head of the pancreas. The head of the pancreas is the most common location for an adenocarcinoma to develop. Distal to the adenocarcinoma, then, we will see dilated pancreatic ducts, and we might note that other midline structures are displaced because of the pancreatic mass. So in our example here, we have the adenocarcinoma, irregular hypoechoic mass in the pancreatic head. We have the rest of the pancreas body down here. We have a dilated pancreatic duct visible here. Adenocarcinomas can develop in other places along the pancreas. They can develop in the tail. When they do develop in the tail, they tend to be larger and more invasive. So it's not uncommon for an adenocarcinoma of the tail to be very large and invade into the spleen. Again, here is the adenocarcinoma in the tail of the pancreas. We have the SMA, the aorta, neck and body, head of the pancreas, and on this side. A common complication of adenocarcinoma, especially a mass in the head of the pancreas, is something called a Courvoisier gallbladder. Courvoisier gallbladders go hand in hand with pancreatitic masses, and that the pancreatic mass causes the bile duct to become blocked, which makes it dilate, and then we see a backup of bile into the gallbladder. So Courvoisier gallbladder is an enlarged gallbladder measuring greater than 10 centimeters in length or 4 centimeters in transverse. This typically is going to cause jaundice in the patient and pain. If a patient is suspected of having adenocarcinoma on your examination, then you want to make sure that you are also evaluating for enlarged lymph nodes and liver mets. All of these structures labeled with an N are nodes at the porta hepatis. We have the liver anterior. We can see part of the right kidney here, and we can see the aorta in the distal part of the picture. So here is our pancreatic mass, and we have metastatic nodes surrounding. Some more key details on adenocarcinoma that are worth knowing is that staging is typically done through CT, but ultrasound can help to evaluate extension of the tumor beyond the pancreas. So we can look if there is any compression of ducts or blood vessels. We can look for lesions within the liver or spleen. We can assess for the size of the spleen and the liver and look for enlarged lymph nodes. Once a patient is diagnosed with adenocarcinoma, there are few options that are available to the patient to treat the adenocarcinoma. Resection or removal of the tumor is preferred when it's possible, but resection is very tricky as the tumors are typically surrounded by some very major blood vessels that run through the middle of our abdomen. One of the more common procedures that will try to be performed is something called the Whipple procedure. So the Whipple procedure are for masses that are within the pancreatic head, which accounts for 75% of the cases. And this is also known as a pancreatico-duodectomy. So that means they're going to remove the head of the pancreas, the gallbladder, some of the bile ducts, and the proximal duodenum. If the adenocarcinoma is found in the tail of the pancreas, then they can do a distal pancreatectomy, where they remove the tail of the pancreas and the spleen if it's invaded into the spleen. Or they can do a total pancreatomy, where they will remove all of the pancreas, and then the patient will need to supplement with insulin injections and take enzyme replacements, usually just in the form of a pill. This picture here shows us the before and after of a Whipple procedure. So we have the stomach, the esophagus, bile ducts, gallbladder, and we can see how the bile ducts connect with the pancreatic duct and enter into the duodenum. Remember, with the Whipple procedure, the gallbladder is removed, so that's gone. It's going to remove the common bile duct, so you can see that area is gone. It's going to remove the head of the pancreas and the first part of the duodenum. So now the bile ducts are sewn directly into the small bowel. Part of the bowel then is also sewn to the rest of the pancreas so that pancreatic juices can continue to flow into the small bowel. And then the jejunum is actually sewn directly to the stomach to allow stomach contents to move directly into the bowel. So this gets rid of all of that kind of central located structures to really resect all of the tumor out from the area. Pancreatic metastases are relatively uncommon. Typically, it's going to be something that they're going to see on autopsy if they see it at all. But we see that melanoma is the most common cancer that metastasizes to the pancreas. Lastly, then, lymphoma is a disease of the lymph nodes. It is the most common parapancreatic neoplasm. And it's actually really difficult to identify enlarged lymph nodes at that midline area compared to a mass within the pancreatic head. So if you see something abnormal in that midline area, it's really important to do your best to figure out, is that an enlarged lymph node outside of the pancreas, or is that something arising from pancreatic tissue? There are other parapancreatic neoplasms that may occur, including lymphangiomas, paragangliomas, and cystic teratomas. Again, though, lymphomas or enlarged lymph nodes are going to be the most common neoplasm that arises from that retroperitoneal parapancreatic space. And that is the end of our pancreatic pathology.